mastication. Remember, we talked a lot about the correct location. Some people were, you know, clear down here around the edge of the mandible. TMJ, you want to be just anterior to the tragus. And sometimes you have to do a little bit of deep palpation. Go ahead and open and close. When they open, your fingers should almost fall into that spot. That's how you know you're in the correct location. Go ahead and open and close a couple times. Good. And so then I'm palpating, and I'm also listening for any audible clicks or palpating for any palpable clicks. And then you go through range of motion. Can you open your mouth, close your mouth? Can you push your bottom teeth out, pull them back in, and go side side to side, right to left. So those are kind of going through the range of motion. And then again, you're palpating all of the muscles of mastication as well. So same as before. Now we're just adding range of motion. All right. Just make sure you're in the right location. So now we're getting into the shoulder. One of the big things that you can document, you know, we talked a lot about on inspection as far as how's your patient sitting. Posture is a big one because we talked a lot about AC joint and the posture piece of it. So even documenting if they have a very shoulder front carry posture, you can document that in your exam. So inspection can go a long way with just posture alone. Again, yes, symmetry. We talked about how nice it is to have, for the most part, bilateral that you have to compare with, looking at the good side first. So, you know, they would be gowned a little bit differently. You can even physically see sometimes enlarged AC joints on each side, but I would be comparing both sides. I would be palpating both sides. There are a lot of landmarks that it goes through here. We talked about the sternoclavicular. You can follow the clavicle down to the sternum. There's not a lot of injuries associated with that. That's why it's not talked about very much. But if you follow that laterally, that's where you're going to hit the AC joint. And again, that can be very tender for people. And some people have very prominent AC joints that you'll see. The coracoid process is always one that's a little bit more difficult. I can show you, but it's going to be deep. Can you feel me kind of pushing on that solid structure there? So I'm not in the clavicle. I'm not on the humeral head. I'm just kind of inferior to that. And when you, you can feel the soft tissue. Let me grab this guy.
Oh, yeah.
So as far as the bone, you've got your humeral head, and then off your scapula, we talked about the acromion that comes around. That is where your rotator cuff muscles sit, in between your humeral head and the acromion. So this is what's called the subacromial space, okay? So that's a lot of these provocative impingement signs. You can see how as I start to move this arm in certain motions, I'm narrowing that space, the subacromial space. So there's your AC joint. Now off the scapula comes your coracoid process, which is, again, it's just a little inferior to your AC joint and medial to the humeral head. So it's kind of awkward to palpate, but that's where that is located. Yeah, it would be right in there. Oh, you can see it on this one too. Okay. And the bicipital groove. So sometimes what helps is you're going to be looking at this. This is what you're looking for. That groove right in through there is where the biceps is. And sometimes what you can do, or what I'm going to be doing on her, is rotating, internal, external rotation. And so you can feel kind of those bony landmarks hitting there. So as you're palpating along the humeral head,
my muscles are so big you can't feel it.
But you feel, I mean, I can feel that, I can feel this bony prominence kind of go right underneath my fingers as I'm rotating her. So that would be the bicipital groove. You can't just palpate it, but sometimes it helps to do that motion with it.
Can I ask a question? Do we have to keep their elbows paralyzed, or no, they can move their elbows? Do they have to go?
You mean as far as location or active or passive? I mean, you want them adducted,
okay,
down, and then you can passively move them.
Okay.
Yeah. Biceps. So the acromioclavicular, we talked a lot about that one. That one's a little bit more prominent and more obvious on people. The subacromial bursa, yeah, not that you can technically palpate that, but just a very good idea of where that is. As again, the most commonly the supraspinatus comes off right through here and would insert out here on the humeral head. And so you can palpate the distal end of that, but most of the location of where there's an issue with the supraspinatus is going to be in the subacromial space. So again, that's not palpable. Insertion you can palpate, but the usually where the issues are not palpable. And again, you'd be doing that bilaterally, especially your AC joints, because they're probably gonna be tender both sides. So range of motion, and again, if the patient is moving it, it is active motion. If they are relaxed and I'm doing it, then that's the passive. So if you do flexion or forward flexion, go ahead all the way, point to the ceiling, keep your elbow straight, good. So that's forward flexion, and then go ahead and relax it down. Keep your elbow straight and point kind of behind you towards the window, there you go. And that's pretty good, extension, good. Now go ahead and relax. Now I want you to raise your hand out towards me and then go all the way to point to the ceiling. Good, and you can relax, back down. And sometimes when people have issues or pain with their rotator cuff, just to look at the motion, you can have them supinate slightly, and it's a lot less tender for them to go up for their motion. And then adduction would be bringing it back down. Remember, you're adding it back down to the body. And then you have internal and external range of motion or rotation. So this will kind of go along with the next, the special test, the Apley scratch test. So there's a couple different ways you can do that. You can either just abduct to 90 and 90 and have them rotate this way, or you can actually do the Apley scratch test, which would thumbs as far down as you can reach, thumbs up as far as you can reach. So those are both ways of looking at internal and external rotation for the shoulder. So the next special test is near impingement sign. And again, doing everything bilaterally. And sometimes it's easier when you're doing shoulder to have them standing. You can if you want. You don't have to, but you certainly can. So sometimes what you do is, with one hand, I want to make sure that I'm kind of compressing her scapula down. So she's not, we talked about that scapulothoracic motion or the scapular winging, you don't want that. And I am going to kind of internally rotate, or if you talk about the forearm, I am going to pronate, so thumb kind of down towards the ground, and then I am passively going to raise her arm up. And that, as you can imagine, doing that motion is really pinching, you're narrowing that subacromial space, and there we go. Oh, okay, much better. Against the humeral head, yes, very nice.
Very loose.
Yeah, it's kind of, but that's the near impingement. The Hawkins-Kennedy one, this one you sometimes might see a little bit, some variance in. If you bring the shoulder to 90 degrees of abduction and then the elbow at 90 degrees, you will sometimes see here, and it's passive, so you would relax and I stabilize the elbow and rotate internally here, or you will also see forward flexion to 90 degrees, elbow at 90 degrees, and then again, internal rotation. So sometimes you'll see a slight variance on if they're straight abducted or if they're forward flexed, but either way, they're both 90. You're gonna, as you can imagine, get a little bit more impingement here, but you're also starting to put pressure on your AC joint there as well. So depending which way you do that, just keep that in mind. The Gerber. So this is, go ahead and turn around for me. So this is a subscapularis all the way. So put your hands on the small of your back, palms out. Just palms open, yep. So what you can do is go ahead and push against me, push my hand away, and push my hand away. Go ahead, push again. There you go. So that's the push off, or that's the Gerber's. Test for that. But again, there are, subscapularis is a little bit harder to isolate because there's a lot of other larger muscles that will recruit as well. So the empty can test, so we're gonna come, again, most of these are gonna be somewhat a type of abduction, and then we're gonna come forward about 30 degrees or so. We're gonna internally rotate or pronate the forearm. Now I want you to hold your arm here and don't let me push down.
Okay.
This is an active provocative test. So, any pain with that?
Nope.
And a lot of these are going to be provocative tests, meaning you are doing them to try to elicit pain from your patient. So you're watching their face, you're asking them if there's going to be pain, those types of things. Drop arm test, wait, we'll do that one and then we'll do the Yeah, I'm gonna skip that and then go back.